Okay, chapter 35 is going to be on obstetrics and your special population patients, which is what we're going to be talking about for the next few chapters. We're going to apply the fundamental knowledge, growth, development, aging, and assessment findings to provide basic and selected advanced emergency care and transportation for a patient with special needs. All right, with obstetrics, we're going to recognize the management of normal delivery, vaginal bleeding, in the pregnant patient, anatomy, physiology, normal. Recognition management of pathophysiology of complications of pregnancy and assessment of pregnant patients. Management of normal delivery, abnormal delivery to include the nuchal cord, prolapse cord, breech fluid, also third trimester bleeding, placenta previa, and the abrupt placenta, recognizing those, spontaneous abortion, miscarriage, ectopic pregnancy, preeclampsia, and eclampsia. And then we're going to look at neonatal care, such as assessment and management of newborn and neonatal resuscitation. As far as trauma, apply fundamental knowledge and provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely. Some special considerations in trauma, such as pregnant patient, pediatric patient, and geriatric. And special considerations trauma with all those and the cognitively impaired patient. So most births require little or no medical interventions beyond basic interventions, such as suctioning, drying, and warming the baby. Others may be life-threatening to both the woman and the baby. The birthing process is a basic maneuver. It can be taken care of by a basic. Yes, we're going to be there as advanced EMTs to watch out for both the mother and the neonate, the newborn itself. So we're going to do some stuff. It's going to be a lot of supportive care and full replacement, and then just making sure you follow AHA guidelines if you do have an arrest situation with either one. So the female reproductive system includes the ovaries, the fallopian tubes, uterus, the cervix, the vagina, and the breast. Pregnancy most frequently occurs during a certain time in the menstrual cycle after the ovum is mature. Process of fetal development following fertilization of egg is gestation. So fertilization usually is in the distal third of the fallopian tube. From the time of fertilization to the end of the 9th week, the development of embryo lasts is an embryo. So from the 10th week forward, it is a fetus. So here is how fertilization is processed. So the umbilical cord connects the placenta to the fetus via the fetal umbilicus. Amniotic sac is the membranous bag that fills with amniotic fluid to protect and cushion the developing fetus. During labor, the pressure on the amniotic sac causes it to rupture, and gestation period is the time it takes the infant to develop in the utero. 40 weeks of pregnancy from prenatal period is divided into 3 trimesters, and the fetal heart tone is audible with a fetoscope at weeks 17 through 20. The female and male genitalia may be distinguished by ultrasound. So ultrasound is basically at week 18. A newborn is a recently born baby for the first few hours of its life. During the first 28 days of life, the baby is considered a neonate. Between the ages of 1 month and 1 year, a baby is referred to as an infant. Normal maternal changes in pregnancy. During pregnancy, many of the body systems undergo changes to support the growing fetus. Total blood volume increases by 50% by 40 weeks, and red blood cells increase by a number by about 30%. Cardiac output increases by 30 to 50%, and in the second and third trimesters of pregnancy, the gravity uterus may compress the woman's inferior vena cava, when she lies supine. And we'll talk about that in emergencies, but don't put a pregnant mother supine. Always lay them on their left side, and this is the reason. Being it releases pressure off the vena cava. All right, complications can occur during the pregnancy that can be threatening to health or life of both the woman and the fetus. Vaginal bleeding is a common early pregnancy emergency. So abortions, most spontaneous abortions occur during the first trimester before the placenta is fully mature. Elective abortion is brought about intentionally and be dispassionate and professional, regardless of your personal convictions. These mothers make a choice. It is not our professional right to make an opinion of them. There still could be a medical emergency there, so please be professional throughout your treatment of this patient. After the call, if you need to go talk to somebody, you can on a one-to-one basis. Be careful to even talk around other people about your opinions. A threatening abortion is an abortion that is impending or potentially occurring, characterized by vaginal bleeding during the first half of the pregnancy, and can progress to a miscarriage or an abortion, and it may subside. Treatment is usually complete bed rest. An imminent abortion is an impeding or threatening spontaneous abortion that cannot be prevented. Maintain the blood pressure and prevent hypovolemia. Treatment consists of 250 ml boluses of saline to maintain the blood pressure greater than 80. Systolic, 100% O2 via non-rebreather, and provide emotional support with rapid transport. An incomplete abortion occurs when parts of the product of conception are expelled, but some remain in the uterus. Vaginal bleeding is present. Be alert for signs and symptoms of shock and start an IV line normal saline. If products of conception are protruding from the vagina, consult medical control for instructions. Complete abortion has occurred when all the products of conception have been expelled. Sometimes abortions are not preventable. Sometimes they happen, and there may be just some complications there. So a lot of these mothers will be upset what's going on. So try to talk them through it, provide that emotional support, but also look at them dynamically and treat for shock. Ectopic pregnancy, implantation, and growth of the embryo outside the uterus. It can implant in the fallopian tube, on the ovary, or in the abdominal cavity, or the peritoneum, or in the cervix. The woman feels lower abdominal pain and cramping. Bleeding may be internal or external, and may be scant or profuse. Can be a life-threatening emergency. The embryo will not survive and must be removed surgically to save the woman. Third trimester bleeding. Any detachment of the ovum or embryo from the uterine wall will result in bleeding. Vaginal bleeding is a serious sign at any stage of pregnancy, but complications increase as the gestation progresses. Third trimester bleeding presents the most dangerous hemorrhage in terms of risk to the mother and the health of the mother. Bleeding in the placenta. Major causes of substantial bleeding before delivery are abruptus placenta and placenta previa. Look for the signs and symptoms that are different in these. These are very major problems you may face, because the mother may not exactly know what's going on, but you may have a good idea. So be familiar with these signs and symptoms in pregnancy. Usually they'll pop up on tests too. The abruptus placenta is premature separation of normally implanted placenta from the wall of the uterus. Risk factors include hypertension, trauma, drug use, alcohol use, diabetes, and having multiple pregnancies. The patient will present with a sudden onset of severe abdominal pain, often radiating to the back. There will also be decreased fetal movement and decreased fetal heart tone. If the hemorrhaging cannot be controlled after delivery, a hysterectomy may be necessary. Placenta previa. Placenta is implanted low in the uterus and partially or fully obscures the cervical canal. Maternal age and multiple priority are risk factors. The complaint includes painless, bright red vaginal bleeding. Hypertensive disorders. Chronic hypertension is defined as a blood pressure that is equal to or greater than 130/80. Diastolic pressures greater or higher than 110. Systolic place the patient at an increased risk for stroke and other cardiovascular dangers. So gestational hypertension develops after 20 weeks of pregnancy in women with previously normal blood pressures and resolves spontaneously in the postpartum period. Preeclampsia increases in blood pressure after the 20th week of gestation. accompanied by protein in the urine and edema. Symptoms include headache, nausea, vomiting, agitation, rapid weight gain, and visual disturbances. Eclampsia is a seizure in a pregnant woman who has preeclampsia and no other cause for the seizure. Postpartum eclampsia can occur up to 4 weeks following the birth. RH sensitization. RH factor is a protein found in the red blood cells of most people. When a woman who is RH negative becomes pregnant by a man who is RH positive and the fetus is RH positive, fetal blood can pass into the woman's circulation and produce maternal antibody to the factor, normally not a factor in the first pregnancy. In subsequent pregnancies, the antibody will aggressively cross the placental barrier to attack the fetal red blood cells, which the woman's body identifies as foreign protein. Can result in death for the fetus and cause hemolytic disease. Gestational diabetes is very common and is an inability to process carbohydrates during pregnancy. The patient may be asymptomatic or exhibit the same signs and observed in patients with diabetes mellitus, polyuria, polydipsia, and polyphagia. Treatment consists of diet control, oral hypoglycemic medication. Patients with diabetes may experience wildly fluctuating blood glucose levels. Gestational diabetes predisposes the patient to hypoglycemia or hypoglycemia. The fetus may grow to a larger than average size and not fit into the birth canal. All right, hyperemesis gravidum, persistent nausea and vomiting during pregnancy results in dehydration and malnutrition. Suspected causes increased hormone levels, stress, and changes in the gastrointestinal system. System includes severe and persistent vomiting in the excess or 3 to 4 times daily. Treatment includes administration of O2, check blood glucose levels, provide an IV normostatin and fluid boluses as needed in transport. Premature rupture of membranes, amniotic sac ruptures or opens more than an hour before labor. If the pregnant is not yet at term, there is a risk for infection. Provide emotional support to the patient in transport. All right, special considerations for trauma in pregnancy. The woman and her fetus are vulnerable to trauma. Severe hemorrhage may occur from injuries to the pregnant uterus. Anatomic changes during pregnancy have important implications for trauma. Relative redistribution of blood volume also occurs during pregnancy. Pregnant women have an increased risk of fall. Aggressively treat a pregnant woman with a mechanism of injury that indicates shock. Substantial maternal bleeding will threaten the life of the fetus. So, a pregnant woman involved in a motor vehicle crash, fall, assault, or other injury must be evaluated at the ED. Management of pregnant women with abdominal trauma is the same as non-pregnant patients. Airway, breathing, and circulation remain the highest priority. So, the examination may reveal an abnormal fetal position, an easily palpated fetus, inability to palpate the top of the uterus, or vaginal bleeding. Transport the patient on the left side with the right hip elevated about 6 inches. Keep your airway high flow too, adequate ventilation, assess your circulation, provide IV fluids. So, even if it is a simple trauma, you need to highly recommend these pregnant patients go to the hospital and have that fetus evaluated. If they do not, highly recommend them go to get evaluated after, they sign a refusal and things like that, just to make sure everything's good inside that fetus. All right, cultural value considerations. Different cultures may view pregnancies differently than you do in terms of social, psychological, and emotional issues. Your responsibility to the patient and is limited to providing care and transport. Respect these differences and honor requests. To teenage pregnancies. Pregnant teenagers may or may not know that they are pregnant and may be in denial about the pregnancy. Respect privacy and need for independence, and if possible, perform your assessment and obtain the patient's history away from her parents. All right, when childbirth is complicated by trauma or other conditions, with any interventions you provide for the patient will benefit the fetus. So, some things you need to be familiar with, and these next 3, 4, 5 things, please become familiar with. Gravida is the number of times a woman has been pregnant. PAIR is the number of times the pregnant woman has given birth. okay, to a viable newborn. This is not abortions. This is not neonates or newborns that have passed. So keep that in mind. Premature gravity is a woman who is pregnant for the first time. Premature para is a woman who has only had one delivery. Multigravida is gravida is a woman who has been pregnant 2 or more times. Nullipary is a woman who has never delivered a viable newborn. Multipary is a woman who has delivered 2 or more viable newborns. And grand multipary is a woman who has delivered 5 or more viable newborns. So always safety first. Take PSI precautions. Get your mechanism of injury and nature in. So assess your ABCDEs. Confirm whether the infant will be delivered in the next few minutes or whether you have time to continue to evaluate the situation. When trauma, vaginal bleeding, or seizures are the presenting complaint, evaluate these first and then assess the effect of these problems on the fetus. If delivery is imminent, prepare to deliver at the scene. If not, prepare for transport and perform the remainder of the assessment and round. Spinal mobilization is indicated. Secure the woman to the backboard and elevate to the right side, or elevate the right side of the board with rolled towels and blankets to prevent spine hypertensive syndrome. Please keep this in mind. If you're going to backboard a pregnant female, elevate the right side. Okay, it keeps the vena cava open. Get your history. Talk about the gravity of the pair. Talk about the length of gestation, estimated due date, and date of confinement. Okay, ask her to describe her pain, identify potential complications prior to the delivery, and ask if the patient whether she's experienced complication with any other pregnancies and where her obstetric or gynecologic complications. Consider delivering a newborn at the same delivery is expected within a few minutes. Some type of catastrophic makes it impossible to reach the hospital and no transportation is available. So how many pregnant weeks are you? It's just your first one. Do you think you're having contractions? How far apart are they? How long do they last? Do you feel the urge to move or move your bowels? This is especially to first-time parents, this is a very good indicator that they're fixing probably to give birth. Have you had any spotting and bleeding? If so, what color and how much? Don't not allow the pregnant woman to get up and go to the bathroom. They may possibly have that newborn in the toilet itself. Reassure her the sensation of needing to move her bowels is normal and that it means they're about to. All right, in your secondary assessment, get a set of vital signs. If you have the capability of getting fetal heart tones or you can at least listen with your stethoscope, that's fine. And full-term delivery usually occurs when contractions are 1 to 2 minutes apart and last about 30 to 60 seconds. Braxton Hicks contractions, intermittent uterine contractions that may occur every 10 to 20 minutes. However, this patient does need to be transported to the ED and they need to be evaluated. Okay. Reassessment, repeat your primary assessment. Check for vaginal bleeding, recheck your interventions and treatments. And if your assessment determines that delivery is imminent, notify staff at the receiving hospital and provide transport. Okay. All right. Spontaneous abortion characterized by vaginal bleeding, abdominal cramping during the first half of pregnancy. Second half of pregnancy, patient may be present with severe abdominal pain caused by strong uterine contractions, substantial vaginal bleeding, and cervical dilation. High flow 2, large bore IVs, and support her emotional without giving a false hook and try to keep her calm. Third trimester bleeding, when it starts, what activity were you doing, how much has been lost, are you having any abdominal pain, what's the nature, is it sharp, cramping, dull, and aching? Use your OPQRST, identifying changes in orthostatic vital signs. And regardless of the source of the hemorrhage, pre-hospital management is the same. A type of pregnancy patient is in severe pain, possibly in hypovolemic shock. Focus on your ABC. Preeclampsia, headache, swelling, anxiety, nausea, and vomiting. Okay. severe preeclampsia, point of edema, shortness of breath, confusion, or other altered level of consciousness, visual disturbances, abdominal pain, myoclonus, and treatment as usual. Supine hypotensive syndrome, management should be include hypo-O2, IV fluids, and administration of dextrose if indicated. With your gestational diabetes, make sure you put blanket rolls on the right side of the board. Stage of labor, onset of labor occurs with contraction of the uterus. And lightning refers to movement of the baby moving down into the pelvis prior to the birth. It's 3 stages. First stage begins with onset of contractions and ends with the cervix is fully efficated or dilated. Second stage of labor is from full cervical efficatement and dilation until the fetus is delivered. Third stage of labor begins with delivery of the newborn and ends with delivery of the placenta. So, get your equipment out, Miss O2. Never attempt to hold the pregnant woman's legs together. Your part is to help guide and support the newborn as it is born. Delivery must occur during transport. Start the vehicle and have your partner assist with the delivery. Always remember that you're going to have 2 patients here. Here's a look at your OB kit, what's in it. These things are going out of date now due to the plastic, so you may want to keep an eye on the date. All right, patient position, limit the patient's exposure, preserve her modesty. If emergency delivery is occurring at home, move the patient to the floor and others sturdy flat surface. Put a pillow or blanket beneath her hips and elevate them approximately 2 to 4 inches and help her to move into a semi-Fowler position. Preparing the delivery field, place towels or sheets on the floor around the delivery area. Open your OB kit carefully so that its contents remain sterile. Wash your hands thoroughly. Provide iodine or scrub solution. Sterile gloves, gowns, goggles, and use sterile sheets and towels from the OB kit to make a sterile delivery field. All right, your partner should be at the patient's head to comfort, soothe, or reassure her during the delivery. Continually assess patient for crowning. Do not allow abrupt delivery to occur. Position yourself so that you can see the perineal area at all times. During the contractions, encourage the patient to rest and breathe. Wrap the newborn so that the face is exposed and that the top of the head is covered. After suction, keep the newborn at the same level of the patient woman's vagina until the umbilical cord is clipped. APGAR scoring, evaluate the accuracy of the newborn's vital functions immediately after birth. There's 5 parameters: heart rate, respiratory effort, muscle tone, reflex, irritability, and color. Each is given a score of 0 to 2, first at 1 minute, and then again at 5 minutes. Keep that in mind. Do APGARs at 1 and 5 after the delivery. Most newborns are vigorous and have a total score of 7 to 10. Newborns with a score of 5 for range are moderately depressed and require resuscitation. Usually it's respiratory in nature. Keep that. All right, clamping the cord should be delayed about 30 seconds after delivery unless newborn requires resuscitation. After the cord stops pulsating, tie and clamp the cord approximately 4 inches, 10 centimeters from the patient's navel, from the newborn's navel, and place the second tie or clamp 2 inches, 5 centimeters from the first tie. Cut between the cords. Examine the ends of the cords to be certain there is no bleeding. Wrap the newborn in a dry blanket and reassess the woman. Prepare for delivery of the placenta. All right, delivery of the placenta usually delivers within a few minutes of the birth, although it may take as long as 30 minutes. Never pull on the end of the umbilical cord to speed the delivery of the placenta. Wrap the entire placenta and umbilical cord in towel and place them in a plastic, if possible, biohazard bag. Place a sterile pad or sanitary napkin over the vagina and straighten the woman's legs. Slow postpartum bleeding by gently massaging the uterus fundus with a firm circular kneading motion. So, massaging the uterus and having the newborn nurse will help contract the uterus and avoid bleeding. Record the time of the birth. After delivery of the newborn, obtain the woman's vital signs. Monitor closely for postpartum hemorrhage and shock, seizure activity, or respiratory difficulty. So, blood loss exceeds 1 pint during the first 24 hours of giving birth. Emergency situations or placenta is not delivered after 30 minutes. More than 500 milliliters of bleeding occurs before delivery of the placenta. Substantial bleeding occurs after the delivery of the placenta. Provide rapid transport to these patients. I usually like to give these patients boluses right after. Anyway, they're going to go through a lot of changes due to that big release of fluid and weight loss. So it kind of helps keep the circulatory status up. However, if they're experiencing a lot of edema, make sure you're always checking lung sound. All right, the definitive treatment for abdominal labor or delivery problems is a cesarean section. If it's preterm, labor that begins in the 20th week or gestation but before the 37th week, this treatment option is a bolus of isotonic crystalloid solutions such as LR or normal saline. Preemie is a newborn that delivers at 36 weeks of gestation and weighs less than 5 pounds at birth. Use supplemental O2 through a tent above the newborn's head and prevent bleeding from the umbilical cord and prevent contamination. Fetal distress may be caused by hypoxia, nuchal cord trauma, abruptive placenta, fetal developmental disabilities, and a prolapsed cord. Rely on the information provided by the woman on the fetus movement. Provide support and rapid transport. Uterine rupture, the greatest risk are women who have had several children and those with a scar on the uterus. A woman who may have initially had very strong and painful contractions and the contractions slacked off and she has a severe abdominal pain. Substantial vaginal bleeding may or may not be obvious. Meconium staining. In cases of fetal distress, the fetus may expel meconium into the amniotic fluid. May result in chemical pneumonia in the newborn. A yellow tint in the amniotic fluid suggests that meconium has been in the amniotic fluid for a while. A green-black color, especially in the presence of particular matter, indicates recent passage of meconium. Be vigilant in regarding the need for suctioning and call for paramedic backup. Multiple gestation, always keep the spare OB kit in your equipment and always consider the possibility of twins or triplets or quadruplets if the uterus is still large and firm after delivery of the first newborn. So if there is more than one fetus, repeat early preparations for delivery. When the first newborn is born, clamp and cut the cord approximately 30 seconds following the birth and keep the second newborn and before the second newborn is delivered. Keep the newborns warm, well oxygenated in a sterile environment as much as possible. So identify the first newborn delivered as baby A, record the time of the birth and of each twin separately. Cephalopelvic disproportion. The head of the fetus is larger than the pelvis. Cesarean section will be required, and it may cause a massive hemorrhage along with postpartum complications. Intrauterine fetal death. Complications of labor and delivery can result in death of the fetus. Grieving parents will be emotionally distraught and will require your professional and supportive skills. Do not attempt to resuscitate an obviously dead newborn. The amniotic fluid embolism, life-threatening condition that is extremely rare. Risk factors include maternal age greater than 35 years, eclampsia, abruptive placenta, placenta previa, uterine rupture, and fetal distress. Amniotic fluid and fetal cells enter the woman's pulmonary and circulatory system through the placenta via the umbilical veins. Signs and symptoms include a sudden onset of respiratory distress and hypertension. Your treatment focuses on the supporting vital systems and to providing rapid transport. Breech. Specific types of breech presentation: sprain, hips flexed, the knees extended, and the buttock has the presenting part. Incomplete, one of the or both hips and knees may be extended with one or both feet as the presenting part. Limb presentation. On rare cases, the presenting part of the newborn is a single arm, leg, or foot. Newborn must be delivered surgically at the hospital. The limb is protruding, cover it with a sterile towel. Place the patient on her back with her head down and hips elevated to prevent further trauma to the newborn that could result in the patient's continued position. Transport rapidly. All right, shoulder dystocia is a woman with diabetes, large fetuses, and the fetuses that are postpartum are an increased risk for death. Occurs after the head has been delivered and the shoulder cannot get past the woman's symphysis pubis. Major concern for the newborn is damage to the brachial nerve plexus. Maneuvers may be attempted to widen the woman's pelvis or reposition the fetus to allow for successful delivery. So remember, your McRoberts maneuver is one of the safest. All right, nuchal cord and umbilical cord is wound tightly around the newborn's neck, which could cause asphyxiation. Slip your fingers under the cord and gently attempt to slip it over the newborn's shoulder and head. If unsuccessful, cut the cord before delivery can continue. The cord is wrapped more than once around the neck. You must clamp and cut only once. Unwrap it from around the neck. Prolapse umbilical cord. Cord emerges from the uterus ahead of the newborn. The blood supply to the newborn may be interrupted. So prevent the woman from pushing and compressing the umbilical cord. Place the patient supine where the lower extremity is elevated. The patient may be placed in a knee to chest position. All right, postpartum complications, uterine inversion. Placenta fails to detach properly and adheres to the uterine wall when it expels. Can result from placing excessive pressure on the uterus during fundal massage or from exerting excess traction of the umbilical cord to hasten the delivery of the placenta. So never use your fingers to try to replace the prolapsed uterus. High flow 2 IV lines, and treatment shot. Pulmonary embolism may be several sources. A blood clot arising from the pelvic circulation is frequent the cause. Suspect if the woman experiences severe dyspnea, tachycardia, and hypertension in the postpartum state. Management is high flow 2 and rapid transport. Spinal bifida, a portion of the spinal cord or meninges may produce outside the vertebrae. Usually occurs in the lower third of the back in the lumbar area. Cover open areas of the spinal cord with a sterile mesh dressing immediately after birth. Maintenance of body temperature is more important than when applying moist dressings. All right, neonatal resuscitation. So the fetus receives oxygen from the placenta. As the fetus is delivered, a rapid series of events may need to occur to enable the newborn to breathe, called fetal transition. Following fetal transition, the neonate breathes and oxygenates his or her own blood. So this shows fetal circulation. Here's some causes of delayed transition in newborns. So fetal distress in utero is usually caused by compressed blood flow in the placenta or in the umbilical cord. After delivery, usually the result of an airway or breathing problem. So persistent cyanosis or bradycardia, hypertension, respiratory depression, or apnea, and poor muscle tone. Your assessment is aimed to stimulate the newborn to begin spontaneously effective breathing, drying, warming the position and suction, and stimulating the neonate. Initial rapid assessment of the newborn may be done simultaneously with treatment intervention. Note the time of delivery and monitor your ABC. Always provide warmth first, clear the airways if necessary, and dry and stimulate the newborn. Position the newborn on a flat surface and ensure an open airway. Additionally, tactile stimulation may be provided briefly to stimulate breathing. Neonatal resuscitation consists of initial states of stabilization, positive pressure ventilation with O2 saturation monitoring, and chest compressions if the heart rate is below 60 beats per minute. All right, consider intubation, continue chest compression with your BVM. The heart rate remains below 60 beats per minute. Administer IV epinephrine 1 to 1,000, and consider hypovolemia or pneumothorax. So it's really based on the key parameters: respiratory effort, heart rate, and acceleration. Free flow oxygen. If the newborn is cyanotic pale, provide supplemental O2. The flow rate should be at 5 liters per minute. Indications of bag mouth ventilation include apnea, inadequate respiratory effort, or a pulse rate less than 100 beats per minute. Signs suggesting a need for bag mask and ventilation: periodic breathing, intercostal retractions, nasal flaring, and groaning on expiration. So always use an emphasized BVM. Make sure it's airtight seal. Use the sniffing position of the head and assess bilateral chest rise and fall and breath sound. So chest compression, two thumb technique, or the thumb technique, and wrapping around, or 2 fingers placed between the side void and an imaginary line drawn between the nipples. All right, biomass ventilation performed during a pause and after every third compression. Adequate ventilation is absolutely critical to successful resuscitation. Vascular access sites include peripheral veins in the intercubical fossa and the saphenous veins. Other access can be obtained at the proximal tibia also. Apnea is common in newborns delivered before 32 weeks of gestation. Apnea does not respond to stimulation. Further steps are not taken. Hypoxemia and bradycardia can occur. So, causes: maternal or infant narcotic exposure, airway or respiratory muscle weakness, septicemia, prolonged difficult labor and delivery, gastroesophageal reflux, and central nervous system abnormalities. So the difference between primary apnea and secondary apnea, always trying to differentiate. The newborns experience a relatively short period of hypoxia. Dryness stimulation may cause resumption of breathing. If hypoxia continues, bag valve BVM assistance is required. All right, bradycardia most frequently a result of inadequate ventilation. Assess patency of the airway. Begin chest compressions if the heart rate is less than 60 beats per minute, despite the 30 seconds of effective PPT. For persistent bradycardia, call early for paramedic backup. Check your blood glucose levels. If it's less than 45 milligrams per deciliter, most newborns remain asymptomatic until the blood glucose level is less than 20. So additional symptoms there. So check the blood glucose level in all sick newborns. Evaluate vital signs. Establish good oxygenation, ventilation, and circulation before managing hypoglycemia. Warm IV fluids can assist in rewarming the newborn who is hypothermic. So hypovolemia, newborns appear pale and have weak pulses, persistent tachycardia or bradycardia, and your 10 nmL per kilogram of isotonic crystal or 5 to 10 minutes. So reassess and provide additional fluids as needed. Will appear cyanotic. Many newborns become centrally pink but have blue hands and feet. If the newborn has a normal breathing pattern and a pulse regular at 100 beats per minute, but maintains central cyanosis of the trunk or the mucous membrane, provide O2. Is to monitor all of this for the patient, the mother itself, but also the newborn.